Welcome everybody. My name is Peter Price. I'm the Manager of Workforce Development at the Northwestern Melbourne Primary Health Network. I'd like to welcome you all today to a really important session that we are collaborating with many of our stakeholders to present a session on supporting people affected by the current crisis in the Middle East. I'd like to begin our meeting by acknowledging the traditional owners of the land on which we're meeting today. For us at Northwest Melbourne, it's the Wurundjeri Woi-wurrung people, the Boonwurrung people and the Wathaurong people. And I'd like to pay my respects to elders past, present and emerging, and any Aboriginal and Torres Strait Islanders in our meeting today. Welcome all. From wherever you are from, welcome. I'd like to highlight that this session has been brought to us tonight in the collaboration of many of our stakeholders, of which we all are bringing together the latest information that we have available. We will acknowledge that this is a rapidly changing, complex and very diverse space. The information that we'll be providing today is as up to date as what we have, and we acknowledge that there may be gaps in that knowledge, although we have brought together our content matter experts in the area today. I'd like to introduce Gemma from Foundation House, who's going to just tell us a little bit about the project that's happening at the moment.
Great, thank you so much, Peter. My name's Gemma and I'm working in the Middle East Crisis Trauma Response Project at Foundation House. It's been set up in response to the events that are occurring in the Middle East, in Israel and the occupied Palestinian territories. The project consists of 4 streams, so community engagement, organisational support, school support, and then therapeutic intervention and support, so direct services. The project was initially established before people were arriving from Israel and the occupied Palestinian territories. So we are wanting to work with communities of refugee background who are living in Victoria, who are affected by these events, regardless of whether they are arriving in this following the recent events. So if you want to reach out to us and get in contact, please do so via email. Our email addresses will be placed into the chat. Thank you.
Excellent, thank you so much. And again, I'd like to acknowledge our collaborators. Just a little bit of housekeeping before we kick off. Just to let you know that attendees are automatically muted, so please ask us any questions via the Q&A button. It's being recorded and you will receive a link. So anyone who's registered will receive a link, and it will also be uploaded onto our resource library. In terms of joining the session, please ensure that your name is correct at the top of your screen or in the middle of your screen, because all those people who have registered for CPD points, unless your name is legible, we won't be able to apply the CPD points to this session. Any issues, please send us a message in the chat. So today's session, we're going to be talking about the current situation in the Middle East, understanding trauma-informed practice and responding to patients and our community. And then we'll be going through a medical response to our arrivals in Victoria, including our resources and referral pathways. We'll have some questions and answers at the end of our Foundation House session, at the end of our medical session. So please pop any questions in the chat or come back to us. I'd now like to introduce Samira and Amira, who are general practitioners that are working in our Northwestern region. Samira has a particular interest in mental health and Amira in refugee health, as well as a variety of other portfolios that they hold and interest areas. They're both from the Australian Islamic Medical Association, and I'll invite them to start.
Thanks, Peter. If you're happy to unshare.
There we go.
Oh, we might need to do a little slide reset here, but hopefully.
Oh, sorry. Yeah. And while we get started, just also introduce Mike and Sherba, who are from Foundation House, who'll be kicking us off. We'll be starting with the current state.
Okay, and all righty. So are we all good again in terms of everyone has a single slide? Wonderful, thanks folks. Okay, thank you everybody for coming along and showing your interest and commitment to responding to the various groups that are coming from the Middle East, obviously in and surrounding the occupied Palestinian territories. And just quickly, you can see our bios here. My name's Mike Bromhead, training facilitator and formerly counsellor advocate within Foundation House. And a welcome to my colleague, Shuba Kokale, who will jump in shortly to introduce yourself. Actually, do that now, Shuba. Say hi.
All right. Well, hello, everyone. I'm Shubha Gokhale, and I'm also at Foundation House. I'm a psychotherapist by profession, and I work there as a practice leader. Mike and I collaborate on training and working with people who have experienced trauma. Glad to be here.
Thanks, Shuba. For those not familiar, Foundation House is a non-profit NGO operating since the late 80s, and our focus is to advance the health, wellbeing and human rights of people from refugee backgrounds who have experienced torture, war and other traumatic events in their journey, including post-arrival context. And we're informed by and align all of our work to 4 primary categories of recovery goal, which we will speak to shortly. And the ways in which we support survivor recovery and wellbeing is via various programs, including counselling, advocacy, school and health sector capacity building, complementary therapies and developing resilience and connection within communities, and informing and trying to influence government policy settings. Information about referral to Foundation House will be linked to the PDF of this presentation, which will be distributed by the PHN. Now, we are assuming that everyone here tonight is focused on building awareness and informed practice around key issues of response to the physical, mental and social health of presenting patients, whilst acknowledging there are many diverse and conflicted feelings and narratives within communities and across the broader community in Australia. We've decided that as much as possible, we will refer to Gaza and the West Bank as the occupied Palestinian territory or territories, that being the official United Nations term for those collective lands. We also recognise that many people arriving in Australia under discussion in this session will come from the territories. There are also affected peoples arriving in Australia who were residing in the State of Israel with different residency status and religious and ethnic identities. Now, as facilitators, we make the commitment to providing a safe space through the program content and our facilitation of any discussions. But we recognise that the reality of trauma and of the events unfolding in the Middle East and other regions is one that will have directly or indirectly touched the lives of everyone in this space and naturally evokes strong feelings, thoughts and opinions. Today, we are focused on enhancing informed professional practice knowledge and responses to new patients arriving and to established community members already here in Australia. So we encourage you to look after yourself, be aware of your own responses to the material. If you need to mentally or literally step out, please feel free to do so and use your personal or professional supports if you need to process your responses to any of the content and the current evolving events. And as always, a little tech patience if things get a little warped. So with that, we're going to step into the current context, and again, I will welcome Dr. Amira Fakhri, from the Australian Islamic Medical Association. Thank you.
Thank-
Amira.
Thanks, Mike. Hi, everyone. Thanks for coming along tonight. So my name is Dr. Amira Fakuri. I'm a GP registrar at Utopia in the western suburbs of Melbourne. Dr. Samira Bayat is a GP who is also a member of the Australian Islamic Medical Association. She'll talk a little bit later on. Just a little bit of our profile, a bit full for two young mums, but we like to stay busy, as you can see. Next slide, thank you. Yep, so just a little bit about the organisation I'm representing. So the Australian Islamic Medical Association is a national organisation with different chapters throughout Australia. So in every state, we've got a representation. Our aim is basically to unite and inspire the Muslim healthcare professionals to serve humanity, mainly obviously within Australia, but on an international level as well. We have a diverse background of professionals from different ethnics, different grades, different localities as well. But I guess as the organisation stands, it's an Islamic Medical Association. And we're part of a similar international coalition from around the world. So just a little bit of background of who we are and who I'm talking on behalf of today. As you know, we all had very little notice when the Gazans were arriving. We basically had about 24, 48 hours saying that Gazans are coming to the airport and we need support, and they are on tourist visas, and they don't have access to Medicare. So we, as part of AIMA, which is the organisation, we put together a subcommittee of nine doctors, so from surgeons to general practitioners, and kind of got together and started doing this initiative that Dr. Samira will speak about a little bit later on. So yeah, that's just what I basically said. So the visitor visa is, I assume, for the Israelis as well as the Gazans. It's a subclass 600, which means it's just a regular tourist visa that anyone would usually apply for, making them ineligible for any Medicare or public hospital services, as well as GP and primary care services. Obviously, there's concerns about accessing care. And fear of cost. Many of them have come from a country of war and have literally come with just the clothes on their backs and not much else with them. So the fear of cost was obviously pertinent and something we had to kind of advocate for. So as an interim plan, we put a pro bono service together, basically a parallel healthcare system, parallel to the Australian healthcare system, but on a pro bono basis. Where we got healthcare professionals from all ranges, all ethnicities and religions involved as well, so not just Muslim doctors, to provide free pro bono services for these Gazans. This is an interim plan until obviously the visa subclass changes and they get Medicare and obviously public hospital access. On that note, we did have a meeting today with the Department of Health. They've approved to extend the asylum seeker policy to include the Gazans. So that means all Gazans, and I assume Israelis as well, can access tertiary public hospital systems, including ED, pathology imaging in the hospital, outpatient appointments and admission surgeries, just like any other asylum seeker. And we're working on the paperwork to circulate on that. So we all are aware that there's a humanitarian crisis in Gaza, and the fact that they've come from an area with a collapse of the healthcare system and civilian infrastructure. We're expecting, worse health outcomes than their counterparts, and we can't deny them healthcare access. It's inequitable to deny them healthcare access. So this is why AIMA on in the interim plan have put this program together. So it all started on 22nd of November when Penny Wong released a statement saying that there's been 800 Gazan visas and 1,800 visas issued to Israelis. So with very short notice, we had to kind of put something together. Currently in Victoria, there's been 560 visas issued for Gazans. So I'm only representing Gazans because I don't have the other information about the Israelis. And currently there's between 50 to 70 Gazans in Victoria. We don't have exact numbers. No one has exact numbers other than DFAT. But apparently they can't release it, or they don't have this information because they had all come on regular tourist visas and not like a humanitarian or refugee visa where they can give us the exact number of people that have arrived. So this is just based on our calculations from community members that have reached out to us saying how many of their family members have arrived. We don't know where they're living, but mainly in the northwestern suburbs. So that's our priority area of I guess, where we're centralizing our healthcare needs. Yeah, so in terms of the visa, it is a 600, subclass 600, which means they all have a sponsor in Australia. So they all must have a close immediate family member. So either a mother, a father, a brother, or a sister. But from our understanding, there was no limit to how many members of their family they could apply for. So we've got some people applying, for 10 or 15 members of their family, which means they've obviously come to a house where there's not enough accommodation, and there's obviously that sponsor cannot financially afford to pay for their healthcare. And they also don't have access to Centrelink payments as well. Just to give in comparison to the Ukrainians, they arrived on a visa 600, very similar, but they were very immediately within a few weeks changed to a subclass 449, which had given them a Medicare card. But in order to switch to a 786, which is the humanitarian visa, they had to undergo the health assessment with Bupa. So they were put on an interim 449 until this health assessment by Bupa was completed. We know that this costs about $450, I think, per family. So it is something that the government needs to take into account, and obviously the cost for the sponsors. Yeah, so there is, I'm not sure someone's put this extra comment in my slide. Maybe they want to comment on it, but apparently, yeah.
I completely forgot to mention that to you, that popping that in to help that part along, it slipped out of my attention. So as said here, the Refugee Legal will be providing a briefing on the 18th of December, because these issues around what Amira has spoken to, these complex sort of visa categories, that's going to start sort of unfolding over the coming weeks and months. So their Refugee Legal are experts in this area, and will be staying abreast of those issues.
Perfect, thank you. Next slide, please. Yep.
I think that's I think your context, Amira. Thanks so much, and being patient for me, slipping that little bit of extra information in there.
Thank you.
All right, and we will be coming back to Amira and Samira a little later on, when we focus in more on health provision. So Shubha and I are going to take us along into stepping into how we sort of understand the impact of these experiences and how we can align our practice, no matter what our profession is, to the lived experience and the reactions and responses that new patients may be having, and also patients who you are seeing who are here in the community. So I am not here to school GPs on the neurobiology of trauma, but we're going to touch into it a little bit, because it is going to be really important to understand that in terms of trauma-informed practice responses, and also maybe giving some education to your clinic staff to help them understand some of the responses of particularly this patient cohort newly arriving. So I guess we just quickly sort of step in and kind of locate actually beyond the neurobiological aspects of trauma is more, in fact, how we understand the lived experience and how individuals and families are impacted at a relational level. So this little quote comes from a book that is not just focused on refugee trauma, but does include it. And Judith Herman is a psychiatrist based in the US and has worked extensively with a range of trauma survivors. I guess really more the emphasis within this that I'm trying to make is that at the heart of our understanding of traumatic experience and the impact of those experiences is the damage to the person's relationship to the self, to others, and to the world that they live in. So how do we kind of locate and understand those responses? Now, as practitioners here today, well understand because these contexts walk through your doors every day, but it is helpful to understand when we're talking about trauma, the two types of trauma. One is the single type or type 1 event. So these are experiences and impact that are more out of the blue. They are more out of context. So we can think about the car accident, natural disasters, and so forth. They don't necessarily have a relationship in an ongoing sense to the person's place in life. But there can be incidents such as a single assault where there can be similar and quite profound impact on the person's sort of future progress. But there are some significant differences in the trajectory of recovery around these types of events. In the refugee context, we're typically more talking about complex trauma, complex in event and complex in the nature of the impact. So typically complex trauma, and GPs will see patients in all sorts of contexts where this is relevant: family violence, child abuse, neglect, people from refugee backgrounds, and the trauma in those contexts, and obviously pertinent to today's context. So these complex trauma speaks to more repetitive and cumulative and chronic events or environments and impact. So as most people within this space will know, if you have people from refugee backgrounds, those patients who are living here in Australia have actually been in extended environments, either in country of origin or displaced in camps or other urban environments before coming to Australia, and would have experienced multiple contexts within environment, multiple experiences of extreme threat and if not actual harm. So this is what we're talking about with complex trauma, that it is typically interpersonal. It is caused by other human beings and can often be in the context of relationships, but obviously in the refugee context, in addition to pre-existing traumatic experiences within family environments, for example, there is also the threatening, if not harmful, experiences within country of origin and along the journey. But of critical note, when we're talking about the emergence of complex trauma presentations, is also about when these events or these environments were experienced at developmental levels. So we know that the earlier in childhood, infancy, childhood, and through adolescence, these type of environments and experiences then have profound impact on personality formation and the sense of the young person in relationship to themselves, to other, and the world that they live in. And we'll speak a little bit more to that as we go. Again, I don't want to school GPs around neurobiology, but as mentioned, I think it is really important that we kind of keep in mind what is going on for patients at different phases, particularly along their journeys. And especially in this context, we are talking about people who have only just recently come out of extreme threat and experiencing harm, experiencing extreme losses, and the horror of war, essentially. So it's essential to kind of understand the underpinnings of the trauma response at this level. Obviously, as we all know, the neurological dynamics obviously protect us when needed, but also can perpetuate unhelpful or dysfunctional responses when that's no longer needed to be so activated. Yeah. So though most health clinicians know this, it's important to reiterate these dynamics so that other supporting staff within GP practice can understand the patient's responses. So I guess that's the primary thing that we want to sort of emphasise is, and why we're going to move to talk about particularly trauma-informed practice in the context of psychological first aid, is, as mentioned, we're going to have patients whose systems, their limbic system, and those instinctive reactive kind of mechanisms of our system are actually highly activated at this point. We're all used to and working with people from refugee backgrounds where, although still quite activated and presenting with different types of sort of reactive responses, the cohort coming out of Gaza and surrounding areas are really going to be highly activated. And so we're going to start to be thinking about what does the individual, and thinking about children, thinking about adolescents and adults, what do they need right now in response from us, and what are they capable of being able to take on? So we'll get to that. So as mentioned, what we're understanding is that in this impact, in terms of the inability at this neurological level to process, we have that dampening down of all of that planning and so forth when people are in that elevated, activated survival mode. Then we have very significant disruption to memory integration. And that is a primary driver of trauma responses over time. And that's why even in a safer environment like Australia, and as things settle, people can still be reactive and feel like the current events feel like they're still experiencing those sort of emotions and reactions as if they were in the past. But we all in this space do understand that responses to extreme stress is quite normal. And this is something we're also wanting to convey to patients. Those initial responses, as mentioned, are protective. But as people, when they arrive here and are hopefully settling and trying to find safe space and essential needs being met and so forth, there may be those same type of coping responses, yeah, in terms of avoidance, dissociation, and so forth, and thus we then start to see an array of different types of responses developing. So there are a range of symptoms an individual might present with, or are being experienced in ways not being expressed or obvious to the health professional. Guilt as a survivor, of having left loved ones behind, of not being able to protect loved ones in the midst of extreme violence and chaos, shame from sexual violence, or again, not being able to protect others from harm. So in the acute aftermath period, episodes of dissociation or detachment, panic attacks, poor memory and concentration are very typical. As we'll discuss shortly, unless there are alarming presentations around the individual's functioning and subsequent safety, these responses are typical and don't necessarily warrant immediate referral to trauma services. We'll have attached some guidance at the end of this presentation around indicators for referral relevant to the different phases of the lifespan, early childhood, adolescence, adulthood, and so forth. So with this lens of understanding around what underpins and perpetuates trauma responses, let's have a look at how that informs our practice responses. Thanks, Shilpa.
Thanks, Mike. So given what we know about complex trauma, we're going to talk about how to create a recovery environment. So we're not just talking about the provision of a service, but the whole setting in which that occurs. And we'll look in a minute at a quote that just emphasizes that our service and our practice responses need to be well informed about the responses to trauma, and that our responses need to be such that they promote safety, agency, and trust in those relationships. Given that complex trauma is caused by an intention to harm and that it occurs in the context of interpersonal relationships, it's crucial that trauma-informed practice responses are also aimed at building trust and at creating recovery relationships. So Mike, if we move to the list of practice principles, you can have a look at those. The emphasis really is on collaboration, on sharing power where possible, recognizing that complex trauma occurs in the context of profound disempowerment and power imbalances, and to promoting a belief that recovery is possible. One of the things that we want to emphasize that while we are thinking about trauma-informed practice responses for our patients, being trauma-informed also means that we as professionals don't fly solo. There's a requirement that we also establish a network of collaboration, of sharing, of supervision, and that we recognize the impact of listening to traumatic experiences on us as well. Without that, we would not be able to respond well to patients, and our practice would be poorer. We're going to move to looking at psychological first aid. And this is really a set of principles aimed at reducing the risk of re-traumatization for people who've experienced very traumatic events, and empowering them through providing information so that they can make more informed decisions about their own health and well-being. So educating patients about the range of responses that are typical or common in response to traumatic events is part of psychological first aid. And we'll look in a minute at the pacing and the use of language that might be appropriate for different ages. What we're emphasizing is that in the first days and weeks, the trauma responses that are common, that you'll be familiar with around hypervigilance, avoidance of reminders of trauma, along with intrusive thoughts and memories, along with difficulties in thinking, processing information, and focusing, that all of these responses are to be expected in the first days and weeks, and that it is only if these responses persist for more than 4 to 6 weeks that we'd be wanting to inquire into what other supports might be needed. And sometimes just knowing that can be reassuring. Psychological first aid is not deep trauma counseling, but it's aimed at establishing a certain level of safety, of trust, of making sure that basic needs have been attended to, and that people know that more help is available if needed. Let's look at some of the responses that are useful in the immediate aftermath of violence. So one of the most helpful things for people in the initial stages is to provide information in a way that they can receive. We know that in the early stages, people's cognitive capacity is reduced, and there's only a certain amount of information that they are able to take in. So it's important to simply inquire and respond to very specific needs and provide information relating to those needs. We expect that there will be quite a range of fluctuation in the way a person presents to us, in their mood from day to day, in their ability to express themselves, in their ability to think, and that it's only after careful observation over a period of time that we'd consider referring them, for example, for trauma counseling. What is helpful in talking to parents is to provide some information and contextualization about how to care for children. What might have been normal in a conflict zone where children are of necessity exposed to very traumatic events around them. It's important to recalibrate and remind parents that for the children to feel more settled, for them to be able to feel calmer, to be able to sleep better, that what would be important is reduce their exposure to anything that is likely to activate their brains or produce reminders of very traumatic experiences. One of the most common ways in which this happens is through exposure to social media, through Facebook or WhatsApp or other channels. And it can really help to reinforce with parents that that's something that they do have some control over to reduce or limit children's access to those traumatic video clips or images.
And possibly also just to add to that is Shubha and I have sort of throughout the years worked in spaces where we've actually been in people's houses, and it's a very common occurrence is adults talking about in front of children the horrors of what is going on overseas or what they've been through and so forth. So maybe also being able to just gently kind of give some suggestion to the parents to really minimize those conversations around children as well.
Yes, thanks, Mike. Another piece of first aid can be simply to alert parents to pay more attention to what the children are bringing up. Children are often overlooked in any context, and especially in the context of traumatic experiences, it can be difficult for the adults in a family who are themselves coping with their own experiences to attend to what children might bring up. And sometimes children will present this information about their experience through their play, through their behavior at school, through their difficulties with sleep, and so on. Some of those somatic presentations are listed in the indicators for referral at the end of this presentation. We're going to briefly introduce you to the Foundation House model of trauma recovery and how we look at working with refugee survivors. So we think that it's essential to think about survivor recovery through these conceptual lenses that link the past traumatic experiences to the current settlement experience, and with all the risks and protective factors contained therein, and with the cross-cultural factors. And we'll talk a little bit more about this in the following slides, recognizing here or emphasizing that trauma is not only in the past, and that part of resettlement, whether it's temporary or more permanent, that there's plenty of scope for re-traumatization or even just the trauma that is experienced during settlement because the experience is here. We can't assume that trauma is in the past. If you look at our recovery framework, you'll see that we link past experience of human rights violations, which all of our patients will have experienced. We link those to psychosocial impacts and the disintegration or destruction of relationships, of attachments, not just to family, but to community, to place, to neighborhood. We link those to internal psychological reactions around anxiety, grief, depression, and also a deeper questioning of the meaning and purpose of life. In some cases, guilt and shame about their own experiences and about the experiences of people who have been left behind. Our recovery goals, therefore, center around restoring not just physical or immediate safety, but restoring a sense of trust, restoring a sense of agency, and having some choice about what unfolds in day-to-day life, promoting connections and relationships, and restoring a sense of dignity and value. So intentionally and very purposefully recognizing and acknowledging the dignity inherent in every human being, treating people with respect, and doing this not just as part of our usual way of going about our work, but really taking care to emphasize that there's something about the purposefulness and intentionality of that care that is quite profoundly effective, given the intentionality of the harm that has affected our patients. Risk and protective factors, there's a range of protective factors that we hope for, whether it's support from family members or support from the community, a welcoming environment at our services, as well as resources that are internal to people who have arrived here, their own strengths and ways of thinking about their life. The risks obviously are manifold. And again, the risks are not only in relation to what's happened in the past, but also taking into account what might be happening to family members overseas. We'll look at cultural factors that affect health and well-being. And one of the things we want to draw attention to is that every encounter is a cross-cultural encounter. What we mean by that is that we as service providers bring our own culture, our own beliefs, value systems, and explanatory models about health. And if we're not aware of that, we can make assumptions about our patients, and we might come into this with preconceived ideas about what their ideas might be. So a very active cross-cultural way of working would be to inquire from our patients about what they believe about their health and well-being, what they think would help them, and what they know about the systems that they are now in. Again, in relation to children, we need to be aware that values and approaches to parenting are likely to be quite different, and that initially the most helpful thing is simply to inquire about what a person's beliefs are before providing any psychoeducation about what our ideas might be. Lastly, trauma-informed practice is not just about individual practitioners, but it's about creating a network of care so that at every level, and I think for patients, one of the most powerful experiences is feeling welcomed at the entry point. We've heard very often from our own clients at Foundation House about how profoundly helpful it is to feel welcomed at reception. So it's not just about GPs or counselors and how we respond to our patients, but at every level, from the CEO downwards, how we think about our clients and patients, what language we use, whether we're willing to listen, willing to share some power, so that our organization's setting is therapeutic and not simply our interventions.
Thanks, Shubha. So in sort of, we'll kind of take those sort of conceptual and practical kind of perspectives and sort of take that a little further into kind of examples of what could be, what are sort of trauma-informed sort of responses, but just a few of the sort of some key kind of communication skills and responses in that context. And it sort of might give a little bit of example, help us sort of see how we might respond to people. Now, again, a lot of what we're presenting here is probably things that I've no doubt you're largely doing. But as Shubha was saying, as a part of a trauma-informed sort of practice is really about the intentionality of knowing, thinking into and knowing that these very, very deliberate and intentional responses are basically very much aligned to supporting recovery. But, so thinking about those recovery goals that Shubha mentioned, these are ways of helping to counter the intentional damage that has occurred in these people's lives, particularly recently. But we're also taking into account, of course, that the recent events are in the context of much longer context of conflict and strife within that region and within that locale that we're sort of focusing on today. So again, these are things that are kind of common sense, but again, thinking about one, what are the type of environments that patients are coming from? What are they used to? Where are their brains at the moment in terms of how they perceive, and they're going to be hypersensitive to language, to the the non-verbal sort of, the body language, and so forth. There's going to be, because of these traumatized brains, quite a hypersensitivity to that. So we're being quite intentional about what we're doing. So thinking about that, the eye contact where it's appropriate, but as we know that when we're trying to elicit and we're taking information, sometimes obviously professionals are recording that as they're going. So we're wanting to be kind of be careful about where our attention is and where it's not. Again, and using that body language that really conveys an openness and a friendliness and safety within the space. Again, the old thing of layperson's words, and obviously you're going to have potentially, if you don't have first language, you're going to be using interpreters. And so you're going to be needing to support the interpreters in what it is you're trying to convey to the patient. As mentioned by Shubha, around having an open, curious mind and questioning to individuals around cultural kind of explanatory models. So we're bringing cultural sensitivity and humility into the space. Checking for understanding. It is often very, very common. I'm sure a lot of very experienced GPs in the space who have worked with this population know that when you ask somebody, do you understand? And they nod, it doesn't mean that they actually understand. There are all sorts of different reasons for why somebody will say yes, when inside they're kind of thinking, what are you talking about? So obviously there's going to be maybe some deference to you as a professional, but also maybe not wanting to be embarrassed or to feel overwhelmed at that point, but maybe not showing it. So checking for understanding, and as a number of you might know about sort of the teach back method, which Joe's a great exponent of, is just to basically say what, so that I can be sure that I have done my job properly, can you tell me what it is that I've recommended to you, or what the treatment plan is, or whatever, and have that person repeat it back. That will help you check into their level of understanding. It also may help you register what is happening in the interpreting sphere, yeah, if you have an interpreter in the space. So, and also just moving through, the ending of the session really refers to, it really connects to this, those recovery goals of safety and control. So really letting the patient know that if this is the case, that you will be seeing them again. You'll be following this, that, or the other thing up. Is there anything else that is urgent that we haven't covered, etc. So it's really honouring and really valuing the person at that very end stage. Now, I'm just going to really briefly run through some, I think, quite important and helpful sort of tips, I guess. So first, where we're again remembering that we've got a people and you know, an internal kind of space that does not feel fully safe at this point in time. So a few tips here, and one of the first things that I really recommend for people, practitioners, no matter what their role, is when asking questions to give the rationale for the question. Yeah, so that really helps the patient to make sense of and make some choices about how and whether they'll answer those questions. Yeah, they need to have a sense of control over what's happening in the exchange of information. Yeah, it also helps kind of minimize confusion or suspicion about the intent of the question. Patients might not necessarily see the sense or assume that you're asking only to do with the health assessment. Yeah, again, people have been through a lot of significant imposition and interrogation, not just over in the trauma of this last 2 months, but remembering the environment that many are actually coming from, is that those have been quite difficult environments for them to exist within, around services and so forth. Some very good service provision within Gaza, but it is also a difficult space. So there's different ways that you can do that, and just rationalising, you know, I need to ask a couple of questions. It'll help me understand the situation or this health problem. Might sound a bit odd. The reason I'm asking is because A, B, or C. Yeah. Also, you can, if you are eliciting information and recognising the GP context is often obviously a much shorter one than a lot of other more thorough sort of assessments in other contexts. But actually having an agreement with the patient is to give sort of dual permission about pausing. Yeah, it's okay for you to pause me, to interrupt me if you're not clear about what I'm saying or you need a break, or for me to maybe kind of just interrupt you so I can get some clarification about what it is you're asking, you know, responding to my question or whatever, and so forth and so on. Yeah, asking questions about what's it been like when you've had to go through a whole range of different interviews at different points along your journey here to Australia. What will be helpful for you in our discussion today? If you're knowing or sensing that there could be some very, very potentially sensitive sort of topics that the person or experiences that the person's holding on to, and I think that's going to be likely the case with this cohort at this point in time, is you can ask the hypothetical question. What would it be like if you and I talked about how this injury or etc. came about, and then we'll move on to some other things. Again, it gives the person some choice in how, when, whether they'll engage in a particular topic. Yeah. And also, of course, thinking about the room, about does the physical environment, does that feel safe for the person? And just asking, obviously in some environments there are noises going off and so forth. Could that be fairly kind of activating or triggering for people? So just checking in about, do you need kind of a quieter space for our assessment or conversation? And we'll forward some information you may be familiar with, but I think it's quite likely that we're going to be seeing patients who, in the course of your assessment around their health needs, which is potentially going to quickly link them back to their experiences over the last couple of months, is you may get a bit of people not fully necessarily associating, but getting those slightly dissociative sort of presentations, people just becoming kind of mentally absent. So there are little grounding and orientation tips that you can kind of use just to help people kind of center. If they're unable to center and be present, then it's probably time to pause the consultation. The person's not actually in the state where they it's appropriate for them to continue. Shubha.
Thanks, Mike. I'll go through these next few slides fairly quickly because a lot of what's on these slides has already been spoken to by Mike. Just a few points that I'll highlight. Sometimes a really crucial part of communication is being able to receive what someone is saying. So if the patient has an experience of really being listened to very carefully, that in itself can be very therapeutic and helpful. There are various tips on that slide around how to reflect back what you've heard verbally and non-verbally, how to check for understanding to make sure you've got the nuance of what someone's saying, and then crucially, how to acknowledge the limits to what you can do. I think that's something that can be very valuable in building trust, to acknowledge that you can only help with some things and not with others. One of the challenges our patients might face is becoming aware as they settle in that there is a range of narratives and beliefs in the community about the situation in Gaza. And that for some people, there might be very little awareness about the experiences that our patients have had. So acknowledging that and alerting them to this range could be very helpful. We'll move on to looking at validation. And again, you can look at this information carefully later, but the key point to emphasize is that validation is not necessarily about agreeing with what someone says or about fact-checking what they're saying. Validation, really, the function of it is to convey that you are taking what a person says seriously, that you value the fact that they want to tell you something, and clarifying your role so that you let people know what would be useful for them to tell you and what might be better reserved for another time or another service. The experience of trauma always has an element of too much. And so limiting what is communicated, containing it, clarifying what can and can't be or would not be helpful to share can be very validating. Once again, inquiring about the patient's point of view, confirming what you see and hear, but asking about what the patient thinks would be helpful. We have a note of caution around self-disclosure. Sometimes it can be helpful to say something like, look, I can understand where you're coming from, or I'd be worried about that too if my parents were there. But it can occasionally be useful, but often it's not necessary. It can shift the focus from the patient's experience to our own emotional experience. And we would recommend keeping it to a minimum. Talking about difficult things, I mean, almost anything or everything that our patients talk about in the aftermath of violence is likely to be difficult. The key thing is for us to show our willingness to listen, to receive, to tolerate what is shared with us, to link people to appropriate supports where we are unable to help, not to argue or get into discussions about facts or beliefs. And when people disclose something, to acknowledge how difficult it might have been for them to share, that there will be a fear of judgment around how that is received, and to support them to say as much or as little as they would like to.
Thanks for that, Shubha. Now, just our last 30 seconds, little kind of quick wrap up here. Excuse me. I need a doctor. Where can I find one? We just a couple of tips here, but Jo Gardner is actually going to speak to this in a slightly fuller kind of way. And some of you will be very familiar with this. Some may not have as much experience in the interpreting engagement. The one or two things that I mainly want to emphasise, and I'll let Jo sort of take it up later, is just sort of really double checking around language and dialect. It's a bit of a tricky one because often we're, and if you don't have first language, I know there are many GPs in the space who do, but if you don't have first language and you are and will need to get interpreters, and I'm referring to the last point on the slide there, is just to try and, as much as you can, check in with the patient if you can, or those who know them, about the dialect. It's a bit difficult to specifically ask for a dialect, but Arabic, there are different dialects being used by professional interpreters, which may be a bit tricky for Arabic speakers, depending on the region they're from. Might be Samira or Amira might be able to give a little guidance around some possible preferred dialects when requesting Arabic interpreters. But we won't do that now. I'll leave that to you guys to deal with later. But that last point here about absolutely avoiding using family, relatives or friends. No, it's an obvious one, and sometimes it's really difficult to avoid it. They're okay for when is that next appointment, but in terms of people saying, no, I prefer my family member who's got good English to help me in the space, as you can, all GPs can appreciate, they're not trained interpreters, so it could potentially be quite inaccurate and places them in a very difficult position of making a mistake. The patient might not disclose if they're feeling that the person who sponsored them or some extended family member is here, is insisting on being in the room with them. They might not disclose important health issues. And of course, for you all, there's a medico-legal risk to all of that. Now, I won't belabor that point. But just a couple of quick practice tips, which we'll leave in here. As Chupa mentioned earlier on, just about really, not just around interpreters, but about all that we're talking about today, just helping your clinic system kind of orientate themselves to this particular population, even if they have a lot of experience of working with people from refugee backgrounds. There may be some quite heightened sort of vulnerabilities that we've spoken to about this population. There's a number of different recall systems and so forth that you can use, which will be attached to resources for you, and translated material and health translation directories. And very lastly, there is the network of torture and trauma services. And I know that I think Samira and Amira have actually referenced this in some slides later on, have the Witness to War National Telephone Service, which can a range of languages in the current kind of context of Ukraine, Afghanistan, and now the occupied territories, will be able to link to people who can respond to patients as an emergency phone number for them, and to members of the community, established members of the community, who are also distressed by what's going on and need support. The very last thing, which I will not go through, but I'll indicate to you, is that there are indicators for referral across the lifespan, about just some indicators that give you a bit of a tip into what you're looking for potentially. But as Chupa mentioned, and we've mentioned, is just keep monitoring this stuff, checking in with parents, for example, about the concerns they have around these behaviours over that first 4 to 6 weeks. If it's persistent or getting worse, then you're thinking about looking at referrals, having conversations around potential referral. Thank you all, and we'll just stop, and it's 5 past, so we're right on our time. So what we're going to defer to is the latest session. So we want the medicos to be able to jump into the space. I'm sure you're interested to listen to them now. And if there are any questions that pop up around Shubha and my information, we can field that later on in the evening. Over to Peter, who is sharing up for our next section.
Hi, everybody. Thank you. I'd like to reintroduce Samira and Amira for our next section. All right, I am sharing slides. Here we go.
Beautiful. Thank you so much, Peter. My name's Dr. Samira, as Peter mentioned, and I'm a GP working in Northgate. I have a special interest in mental health, and I've been working alongside Amira with the Australian Islamic Medical Association. We work in a subcommittee, which is a Ghazni Medical Response Committee, and our aim is to propose a temporary solution to assist with the healthcare of the Ghaznis when they arrive, so that they will have access to health. As Dr. Amira already mentioned, the Ghaznis are coming on a tourist visa, so they will be ineligible for Medicare. Sorry, Peter, could you just change the slide? Thank you. And so in recognition that they lack Medicare, we're aware that when they arrive, it'll be difficult for them to access health in Australia, especially given the fact that many of them are coming without money or anything other than the clothes on their back. So as a response to this, we've formed a committee, and in the last 2 weeks, we've been working extremely hard to propose a temporary solution to assist them to access the healthcare that they require. The first step that we did was try and identify other healthcare professionals who would be willing to provide healthcare pro bono to the Ghaznis. And to be able to do this, we created a QR code which linked to a form where we could confidentially identify healthcare professionals, including doctors, surgeons, physicians, allied health like speech pathology, pharmacists, social workers, optometrists, and dentists who would be willing to provide healthcare to these individuals for a pro bono reason. And to date, so just in the last 2 weeks, we've managed to identify 440 health professionals who are willing to provide care, which is very kind of them. So this was the QR code that we developed and we've shared. And so for anyone that's interested, you're welcome to scan that QR code and register your interest. What we've been doing with that information is understanding the location of the health professionals that have offered to do their help. And this will allow us going forward to link the individuals with health professionals in their area. So we've been, in addition to setting up a temporary parallel health service, we've also been working on advocacy for more longer term goals so that the Ghaznis will be able to access healthcare in a more appropriate and sustainable way. And so today we met with the Department of Health and Aged Care, who have approved the extension of the asylum seeker policy so that if these individuals do require hospital care, including access to tertiary public hospitals, such as emergency, inpatient admission, outpatient appointments, then they will be able to access that. And in addition to this, we identified that for patients requiring emergency services such as ambulance and that may not be able to afford this, then an ambulance waiver can be sought for this. And just on that note, it's really important because these individuals are coming with such little resources and money. One of the fears is around their ability to access healthcare. And so they're scared to actually present to hospital for fear that they'll be given a bill that they won't be able to pay. So it's really important for us to encourage them that if they do need to seek health, that we are here to support them and that healthcare can be provided for them. So as I mentioned, we have collected a database of health practitioners who are willing to assist. Within this database, we've then made subcategories. And so we have identified GPs that will be able to provide primary healthcare for these individuals. And as I mentioned, we've used this information to map it on a live Google map. So when people are needing to seek care, they can look on that map and find which doctors are available that are in close proximity. Because another thing that we identified is the difficulty with transport or being able to get to their appointments. So this is an important tool that we've developed. In addition to this, we have ophthalmologist group to support the Gazans with eye trauma that they may have experienced. And another area that we identify they may have challenges with is dental emergencies. So we have arranged a group of dentists to provide support for this as well. As I mentioned, in addition to these, there are other specialists, including surgeons, physicians, and a range of other health professionals like Allied Health who are willing to provide care so that we can provide a temporary network until we can get more long-term solution. Having said this, we're conscious that it's December, and so a lot of people are going on leave. So it's really important that we continue to advocate for a longer-term solution. So in addition to this, it's really important that we communicate with the Gazans how they can access healthcare. We acknowledge that coming from another country, there is a lot of learning that they need to do, and our health system is likely very different to what they have come from. So to simplify the process, we have created 2 flyers, which just summarize how they can seek healthcare as needed. And so we've divided that into urgent care. So for emergencies, it's important that they seek hospital care. If it's semi-urgent, they can get care through the primary acute care clinics that have been established. And then if it's less urgent, then primary health care, and that comes down to that map and triaging them. We've also on that fact sheet given information about what type of presentations and examples of what sort of health conditions would require access to which different services. And then acknowledging that many of these individuals will be speaking Arabic only, we created the fact sheets in Arabic as well. And similarly, we've created some videos that cover that same information. So if it's easier for them to do that, they can be able to access that. We've also done some fact sheets on the primary care clinics and just a list of which services can be managed in those services. Unfortunately, we've been more recently advised that they don't have access to pathology and radiology in these services. So although they can access the acute care, there is going to be a bit of a challenge in terms of accessing radiology and pathology if that's required, because that's not funded under these services. I think that slide had the video, so that's okay. We can move on from that one.
Yeah. Oh, there we go.
So I'm not sure if they will work, but they're just the 2 videos that we created that we can distribute to community members so that they know how that they can access care. And we again produce that in both English and Arabic in case of language barriers. So what have we achieved so far? As we mentioned, the large number of visas have been approved. However, there has been a holdup at the border. And so as a result of that, we estimate that approximately 50 to 70 individuals are in Victoria at present. And of these individuals, we have already been able to assist 22 cases. From these cases, there's been a variety of different conditions that we've seen. These include acute cases where we've linked in with primary care clinics. There's been a case that's required tertiary care, and so we've managed to link them up with a hospital. And then for the less acute cases, as mentioned, we've been linking them with GPs in the area who've been willing to provide some pro bono care. At present, although we have offered mental health services, they're currently have been declining these services. And so as acknowledged in Mike and Subha's talk, you know, this could be that they're adjusting, we're in the first aid stage. And so I guess as they feel more comfortable in the community and begin to settle, then hopefully they'll be able to reach out and access this support as needed. So as I mentioned, in addition to identifying health providers that are able to provide care, it's important to link them to other services within the community. And I guess by doing this role, it's made me really appreciate how lucky we are in Australia and how Medicare does provide us access to both medications, pathology, radiology. But when you don't have access to that, you realize how challenging a health system is to navigate. And so in lieu of this, we've had to approach pharmacies and get support from certain companies to provide free medications. And so Pharmacy for Less have kindly offered us either free or subsidized access to medication for these individuals. We've had some support from St. Vincent's Hospital, who have offered to subsidize the cost of some surgeries if we require. And Sunshine Private Hospital has also kindly offered this as well. We've had support from Spectacle Hub in regards to free checks and glasses. And we've linked in with some radiologists, including Vision Radiology, IMED, FMIG, and Capital, who we're in negotiations with, offering some free imaging from them as well to provide that support. And in regards to pathology, St. Vincent's has offered to help with pathology for these patients as required. And in addition to this, we've managed to get them access for mental health support from Foundation House. So thank you very kindly for offering that. It will be very important, especially after what these people have experienced. Access to priority primary care centres in Victoria, as we mentioned. The Royal Children's Hospital Refugee Clinic have been very kind in offering their help to the children who've been arriving. Melbourne Council offering free immunisations. And these individuals will also have access to Asylum Seeker Resource Centre and Cabrini Health Service. So that's just amazing to get some temporary healthcare solutions while we work on a more longer term sustainable solution. And in addition to that, Monash Health Refugee Clinic has also offered their care. We've got access to Victorian Virtual ED. The Australian College of Optometry have also offered eye checks and free glasses. Witness to War, as Mike has mentioned, is a multilingual telephone hotline who will also be able to provide support, and then also support from Red Cross Migration and My Aged Care. So as we mentioned, we in the interim will continue to support these patients pro bono because they don't have access to Medicare, and they themselves don't have the finances to fund their own healthcare. But hopefully, as we continue, we will continue to advocate for access to tertiary public health system. And so that was really incredible to have the meeting with the department, who were willing to support us as needed to access hospital services. And also we're able to refer for ongoing support from CoHealth, IPC, Monash Refugee Health, and Cabrini and the ACRC. And then lastly, as we mentioned, we're working with the Department of Health for a longer term solution. So we're aware that when the Ukrainians arrive, a circular was sent around to all the hospitals, just acknowledging that they'd be able to receive healthcare from that and from them, both as emergency services, inpatient and outpatient, admitted or non-admitted. As a longer term solution, we need to work on humanitarian visa options so that hopefully long term they'll be able to access Medicare, and with that more easy access to primary healthcare, radiology, pathology, and pharmaceuticals. In addition, we're working with other community stakeholders for their support. So just as a disclaimer, we are completely pro bono. We have no monetary involvement in this project. And we're very clear in saying that we're not responsible for any bills that may have be associated with advocating for the healthcare needs.
Great,
Thank you.
thank you.
Thank you so much.
Thank you so much, Samira. I'd now like to introduce our next speakers, Dr. Joanne Gardner and Dr. Karen Linton, who are both general practitioners who are working with our local community as refugee and asylum seekers with a range of different experience that they bring to us today, of which you can read more of in these bios. Importantly, they are working currently within this space.
Okay, thanks, Peter. Karen is going to join me for questions, and I will go quickly to make sure that we leave plenty of time for questions. All these slides will be available, and I will have, most of them are resources anyway. So basically, a few slides are here just to remind us of what people coming from the occupied territories are dealing with. And they are official slides such as United Nations Relief and Works Agency. Thanks, Peter. The next slide. And of course, the most accurate, most up-to-date information I could get from these agencies, as we know that not only are people being killed, but also United Nations workers also. Thanks, Peter. Next slide. And many people internally displaced and things absolutely terrible, as we know. Thanks, Peter. And also what I want to highlight is the illnesses that are breaking out. And my thanks to my colleague, Dr. Janet Pasricha, who's the Adult Refugee Health Fellow at the Royal Melbourne Hospital, an ID physician. Respiratory infections, skin and lice infections, diarrhea, impetigo, chickenpox, and hepatitis A and other causes of jaundice. Thank you, Peter. Of course, healthcare was difficult, a very crowded area, many people needing care and perhaps difficulty accessing care. And of course now, as we know, hospitals have stopped working and everything is getting worse and worse. Thanks, Peter. I'll just let people look at that for a moment. Thanks, Peter. And of course, water, sanitation and hygiene getting worse and worse. One toilet for every 600 people and water running out. Thanks, Peter. Okay, a few quick points about using an interpreter from a medical point of view. Thanks, Peter. Okay, just keep pressing until all the things come up. Okay, thanks. Backwards. Okay. So my preferred phone number, which is much quicker than the doctor's priority line, is the actual booking line number, 1300 655 070. You get straight through to a human and you can find the interpreter very quickly. You need a TIS code. You can have both on-site and phone interpreters booked through TIS, and your reception staff can pre-book for you. Now, TIS is generally for Medicare-funded consultations, but having said that, TIS has recently been opened up for certain non-Medicare funded consultations, including the mental health service I work at in Geelong, which does not use Medicare. So GPs are obviously reluctant to do anything that they feel is not completely tickety-boo, but I would argue that it's crucial that if you're dealing with an asylum seeker or someone who doesn't have access to Medicare, your first point is to get accurate medical information to make the correct diagnosis and treat the individual in front of you. The second point, that one should really try never to use friends and family members to interpret. So medico-legally, I can justify using TIS. The other thing is you do not have to give the client's name when you ring that number. I always say the client's name is confidential because that avoids me having to spell it out, and that saves me a lot of time. Thank you. Keep going. Yep. So basically, sorry, backwards. The patient's name's confidential. I usually brief the interpreter, particularly just to say whether or not I've met the patient before, if I'm just giving results, if I'm following up on a mental health problem that I know well. In a very specific situation, I will explain that I'm doing a mental health assessment or a cognitive assessment, or perhaps even taking a sexual health history to make sure that the interpreter knows why I'm asking particular questions. I always remind both the client and the interpreter that the interpreter's role is confidential. I record the job number just in case I need to, in case the connection breaks and I need to get the same interpreter back, or in very rare cases, I may want to complain about the interpreter or not have them again because the dialect is wrong or some other issue. I always, if I'm doing a phone consultation, I always watch my client to make sure they're happy with the interpreter, and you can usually tell. I speak in the first person, and the reason that the traffic cop is there is that I try to control the conversation by encouraging information from the patient, stopping them when they take a breath, and then encouraging the interpretation from the interpreter. And that way I keep control. The interpreter relaxes, the client begins to look at me, and I know that I'm getting all the information I need. And I try to stop excess clarification, politely, of course. In terms of special confidentiality, occasionally you can ask for an interstate interpreter. And if you have a sense that the client wants to tell you something deeply confidential, you can sometimes change the client's name. And in fact, I've changed the client's name and the name of every member of their family and used an interstate interpreter to make sure I got the whole story if I needed it. Thanks, Peter. Next slide. Okay, so I have a little template when I'm taking history, and very briefly, I ask about the country of origin, the preferred language, which often gives you a lot of information about possible trauma history, e.g. a person from Myanmar who speaks Rohingya has by definition experienced some sort of trauma for themselves or their community. I ask about the need for an interpreter. I ask when they arrived, because if they arrived recently, they may have a different level of need to if they arrived 10 years ago. I ask about their visa status because, again, depending on their visa status, they will have access to more or less care than another person. And occasionally, if relevant, I ask for if they've experienced detention in Australia or detention via Nauru or Manus, etc., which may impact on their mental health. I always ask about settlement and services and those very basic things about how they're settling in, and very crucially, who is helping them. And if necessary, we look at the mobile phone to go together and we go through the text messages. I check in for screening, and I'll talk about screening in a moment. And if I'm not sure about screening, I'll complete it or do it again. I'll ask about physical health problems and what specialists they've seen in the past. It's not unusual to have a patient who goes to 3 different hospitals for 3 different body parts, and neither hospital knows what the other is doing, which is very frustrating. And again, mobile phone messages often are very useful for working out where the patient is going and for what. I ask about the psychosocial issues, and in terms of quickly screening, my 3 favourite questions: how are you sleeping? Checking into mood, and asking if there are any big worries, which is usually a nice, easy phrase for an interpreter to translate and gets me all sort of really useful information. I also think about who they're separated from. I may not ask that straight away, but who is missing, who is left behind, who is deceased, who may they be grieving, because this is often a cause of their presentation. And then I think about how am I going to make a team to support them and myself. Thanks, Peter. Next slide. These are common, this is Australian data from about 2008, courtesy of the wonderful Dr. Georgie Paxton of the Royal Children's Immigrant Child Health Clinic. And this shows the common things that are picked up in refugee health screening. Thanks, Peter. Next slide. So these are the things that we think are really important not to miss. And basically, a febrile illness or an acute illness post-arrival may be malaria and always has to be excluded. In this context, particularly clients with hepatitis of various kinds, parasitic or diarrheal disease in this particular cohort, if they've just arrived, lice, scabies, active TB, undiagnosed HIV, Hep B, Hep C or syphilis. Obviously, in ward contexts, women, children, men are more likely to be assaulted than in other more settled contexts. Undiagnosed strongyloides, and of course psychiatric disorders, particularly dissociative disorders or psychotic disorders. Thanks, Peter. Other things that we often find: schistosomiasis, subacute problems, skin problems such as leishmaniasis, even leprosy, symptomatic Helicobacter pylori infection, which can include the whole family, deficiency states, particularly vitamin D, iron, B12, eosinophilia almost always is parasite infestation till proven otherwise. And if you can't fix it, you need to refer to an ID physician. And this was common in the Afghan cohort as well. Poor management of chronic disease, diabetes, developmental disorders. People are coming in with those, chronic pain and somatization, and very, very crucially, particularly for refugees or asylum seekers who've had a peripatetic or mobile existence in Australia, delayed diagnosis of common problems, failure to use interpreters, or uncoordinated and fragmented medical care, which is very common. Thanks, Peter. Yellow flags, we talk about psychosocial problems related to resettlement, sponsorship breakdown, and, you know, the intense complexity of housing. And I'm not talking here about people arriving from Gaza. I'm talking about a sponsorship situation where one family sponsors another family member or another family. They move into their already crowded house. Often the relationship goes badly. Interpersonal violence, which can occur when spouses reunite, for example. And then we have a lot of common problems, which I won't go into in too much detail at the moment. Thanks, Peter. Common psychological problems, well, Mike and Shuba have already alluded to many of these, but we see a lot of PTSD and complex PTSD, which is that PTSD that affects relationships and view of self and the world. Sometimes, and that overlaps a little bit with borderline personality disorders, but mental health units often diagnose complex PTSD in refugees and asylum seekers inappropriately, in my view, as borderline personality disorder. So that can make tertiary mental health treatment a bit complicated. Depression and anxiety, grief, somatization, etc. Very, very important is what Mike and Shuba alluded to, cognitive problems, dissociation, which can make learning English very difficult for people. Thanks, Peter. Now, I don't need to say too much here. Much of this is contained in the Refugee Health Assessment template, which was based on the elderly person's assessment template from several years ago. We thought it would be useful to make one for refugees and new arrivals. And even if you can't bill it, it's still quite a good guideline for what to think about, what to check, and even how to ask questions. Thanks, Peter. Basically, if you were seeing a newly arrived person from Gaza and you were worried about, these would be very, very reasonable investigations to order. A full blood count, hepatitis B serology, and all 3 moieties must be written, because otherwise, if you just write surface antibody, you won't know if they're surface antigen positive, and you won't know their immune status. So it's really crucial. And if they're core antibody positive, that might have implications for treatment if they have immune deficiencies or need chemotherapy, etc. Hepatitis C, strongyloides, HIV, and latent TB screening. MAN2 test if under 5, quantiferin gold if over 5. Thank you, Peter. Age and risk-based, we check for varicella, rubella immunity. We check fasting glucose or hemoglobin A1C, lipids, ferritin, very important for this cohort, vitamin D with some extra stuff for children, and B12. Thanks, Peter. And again, syphilis serology, FPU, and Helicobacter. Please don't test serology for Helicobacter. Oh, yes, I want to make another point. We're taught in Australia to ask very detailed and intrusive questions about sexual activity, and that's great. However, it's really inappropriate for most refugees and asylum seekers, so please don't do it. It's very hard to do it sensitively. Helicobacter, don't test serology. You do need to do a stool antigen or a breath test to test for active infection. Stool microscopy and OCP if they've got symptoms. And country-based schistosomiasis and malaria. Thanks, Peter. Okay, we also recommend everybody get their eyes checked, particularly African patients over the age of 40 are at increased risk of glaucoma. Hearing if needed, and check people's ears because often they've got perforations and there may be hearing damage from obviously bombs and explosions, etc. Everyone needs a dental review, a mental health screen, women's health, etc. and cancer screening as per guidelines. Thanks, Peter. Catch-up immunisation, I won't reiterate this, but for asylum seekers and refugees, people do have access to catch-up immunisations, which is fantastic. Thanks, Peter. Psychological screening, I just want to say a couple of things here. Asking about energy, sleep, appetite, concentration and memory, everyday interests and managing to do everyday tasks. Suddenly fearful is a really useful question, and big worries. Now, a very useful screening tool, which was designed for people who were not clinical, in fact, is the STAR-MH, and I've got the link there. The K10 can be found in different languages, which makes it a tiny bit more useful. And the International Trauma Questionnaire is also very useful for looking at complex trauma. Now, these tools might be useful if you were writing a medical report or you were trying to provide some evidence to a government agency about someone's mental health. That's where I find that they're most useful. Thanks, Peter. Okay, now to run through some resources very quickly. There is an up-to-date chapter on refugee health in MIRTA. Thanks. Yep. The Australian Refugee Health Practice Guide, which is fantastic. Everything you need to know is in there. It's very, very good. Thank you. I want to commend the Royal Children's Hospital Immigrant Child Health Service, who have an absolutely wonderful website, and they're a fantastic service. They write, their medical reports are like War and Peace. They're very long and comprehensive. Absolutely fantastic. Thank you. Also, the Australian guidelines for post-traumatic stress disorder were written by an alumnus of Foundation House, Mr. Guy Coffey, and it's an excellent chapter on caring for refugees and asylum seekers, as well as obviously the wonderful resources that Foundation House provides. Thanks, Peter. Now, just a few things. We have the Refugee Health Program, which began in 2005, and there's basically a refugee health nurse located at every community health service, and they're fantastic if you need any support. I wanted to mention Refugee Health Fellows. So the state government funds 3 fellows or 2 fellows at the Royal Children's, 2 fellows at the Royal Melbourne, myself and my colleague Janet, the ID physician, and a refugee health fellow who's a GP named Larissa at Monash. So we love getting phone calls from GPs and settlement workers and refugee health nurses, and we are happy to answer phone calls or emails at any time. Obviously, the Victorian Refugee Health Network, which has been mentioned before. There's also the Refugee Health Network of Australia that now has a website, and the Victorian Refugee Health Network is part of that national organisation. And for those really interested in this, I wanted to say that there is the RACGP has a special interest group in migrant, refugee and asylum seeker health, a very vigorous and fun, lovely group of people passionate about this area. Thanks, Peter. There's some useful translated information websites, which I will leave with you. Thanks, Peter. Just a couple of things about health pathways. Now, there's a few slides coming up about health pathways, but basically the username is connected and the password is healthcare. So connected healthcare. So that's easy to remember. And that's how you log on. Thanks, Peter. Yep, I'm going to whiz through these. So there is a special section for health assessment for refugees and people seeking asylum, which you can find easily. Thanks, Peter. Just keep going. All about how to do an assessment, all about the different visas, incredibly useful. Thanks, Peter. And how to get hold of interpreters, about catch-up immunisations, red flags, which we've already talked about. Thanks, Peter. And how to get referrals and referral pathways. Thank you. And services for mental health, which is great. Further information and other pathways that might be useful. Thank you. And that's how you find it. Okay, so last few slides very, very quickly. So as everyone has said, the most important thing we can do for this cohort and for our communities is try to establish safety, hence Maslow's hierarchy of needs. So try where we can to assist with a safe environment, whether it's housing, ensuring that Centrelink aren't cutting off people's income for no reason, which they are apt to do, trying to assist with sponsorship of family members and advocacy to help people feel safe, because as has been said, people don't feel safe if their relatives overseas are not safe. They just don't. What we can do to help them have a safe, healthy body. And the therapeutic relationship is crucial. This is where often the GP is the constant in an ever-changing sea of health workers, social workers, specialists. The GP is often the constant, and establishing a really good therapeutic relationship can be incredibly helpful for safety. Assessment and screening, explanation, manage problems, and then, of course, a safe mind. So normalizing and explaining symptoms, gentle symptom relief, as we've talked about. Thanks, Peter. So again, this is what I find really helpful in terms of making people feel comfortable. I call it therapeutic kindness, greeting people with warmth, with a twinkle in my eye, with a very big smile, really deliberate welcome. Welcome to this country. We're so glad you're here. I hope everything goes well. Therapeutic touch that's appropriate, taking time, being patient, seeing the person again, not expecting to get everything out at once, small bites, let the person get to know you and have trust. Be led by what the patient's worried about, thinking about how the patient can access your service. It's not always easy for them to get past the dragons who are on reception. So how do you help them do that? Advocate, but also be very clear about your boundaries, what you can and cannot do, e.g. writing prescriptions for medicine overseas, and be transparent about what you can and cannot do. And the attunement, very simple stuff that good GPs do automatically, observing people carefully, which using an interpreter makes it very easy to do because you've got double the time, mirroring the posture, breathing, positive regard, and offer hope. And the crucial thing we can do is remind your patient of their strengths. What's got them out of bed? What's got them this far? One of the most useful things is to help them tap into their strength. Thank you. Next slide. Okay. So finally, just keep tapping those buttons. Identify people, find out who else is involved, take time and use a professional interpreter, build the therapeutic relationship, be guided what the person is bringing to you. You have your list, but let the patient's list trump your list as much as you can. Advocacy, focus on function, even if you can't completely cure their depression or their chronic pain, focus on function. Be aware about family separation and embed good practice systems, as Mike and Shuba were talking about. Thank you. Thank you. My colleague Karen, working beautifully with a refugee family in Footscray. All right, that's it from me. I think we've got time for questions.
Definitely time for questions. I might just go to the Q&A. I think there's already been one in here about getting information out to the community. Can you provide contact details for the North West Melbourne to distribute to GP clinics in the catchment? But yes, Samira will send some information around. And just checking in the chat, is there anything that's come up in the chat that people may have?
I went really fast. Did Karen have anything that you wanted to add? Because I did go like the road runner.
I think you almost covered everything, Joanne. My only last thing is to just check if somebody is pregnant. I always say a woman is pregnant until proven otherwise in this scenario.
Yep.
Probably goes with any woman in any scenario of gestational age.
Great. There was some discussions about funding. Joanne had talked about identifying by letter in terms of reception to make sure you identify patients. What's that? What do you mean by that, Joanne?
So I think I was bombarding poor Amira with this one, but people turn up to, e.g. the Royal Melbourne Hospital that I know well, and if they're not correctly identified as an asylum seeker, despite one's best efforts to educate everybody, they will be slapped with a bill or sent away or something horrible happens. So the ASRC provide people with a card, an identification card. I'm not quite sure what Cabrini Asylum Seeker Health Hub do, but sometimes a letter suffices. So I was just going to say that if and Amira's organisation, I think, will be providing people with a letter, but it's really important that people are provided with a letter on letterhead explaining their circumstances briefly and perhaps with the contact details of the referrer to ensure that this can be followed up if the receptionist or doctor or whoever is unsure?
Just to add to that, I think that's really important for emergency department presentations in particular. And, you know, people will get sent away or be told they're going to have to pay. So any way of putting a big header as approved by the Victorian government for this new arrival from X, Y, or Z, the fee will be waived. I think also in the chat it was that Kath Despite from the Refugee Health Program is getting a letter set up. Is that right, Amira? Is that what you posted in the chat?
Yeah, so when we had our meeting today with the Department of Health, they did say that the Victorian Refugee Health Network will do a letter for us, and I've spoken to Kath. It will be a very generic letter, and I guess it's basically just to get us through the Christmas period. So, and then I guess we can do more formal things early next year to get access, like just emailing out on a Commonwealth level that these Gazans and Israelis have you know, access to public systems.
There was also a question in the chat around the priority primary care centres. So as you'll know, priority primary care centres are available for anyone with or without a Medicare card. So they will be seen and assessed for urgent care. So we call urgent care same day care. So something that you need today, not something you need tomorrow, but something you need today. However, there may be some costs in terms of pathology and radiology. So that can be a barrier. However, any urgent care that requires any of the care that is urgent, they will be assessed and given the most appropriate care they can. So any other questions from anyone in the chat or anyone? I think there was just a comment around dangerous for asking people to determine if their care is urgent. I agree. Again, we are going with do you need to see someone today as our way of guiding people, and you know, not everyone gets it right and people won't get it right, but I think as general practitioners our audience will know what that is. So if you're contacted or anyone asks you some questions, I think we all in this room know what urgent means. And so I suppose it's just really the more that we understand in our community around priority primary care centres, the better we can support the right care at the right place. So, but I do agree, it is challenging.
And that's why we've set up some fact sheets to provide to these individuals so they can help them understand what's urgent and give examples of presentations that might need access to that care.
Yep. I know that there was, I think, was it Amira? Did you have a patient that came through that needed urgent care? And what was that case scenario that you saw?
Yeah, so we did have a patient who we referred to urgent care. It was a wound that was post-op wound. It was infected, so it met that criteria of an acute wound. However, it had sutures in it, so they refused to take out the sutures because that was a chronic condition and not acute. And so that was, yeah, and we had to really advocate for that patient, and they hung around for a little while until we got there in the end. But it just kind of, I guess, words, you know, the word, you know, it will go through the community really quickly, and they'll just say, oh, don't bother going there. And then that's when we get the issues where we're trying to find them GPs that are available within a day or two, and obviously the GP is not paid for it. So yeah, I guess that's one of the situations. So we just have to be really careful who we refer to the PPCCs and make sure their criteria is met. We've tried to kind of speak to them, I guess, through the Victorian Refugee Health Network to just have a bit more flexibility for the Gazans, but unfortunately we haven't been able to achieve anything.
So there's a lot of conversations. As you know, this is a very emerging topic, and there is a lot of conversations happening at the PHN. So the Northwestern Melbourne PHN is actually the lead for the state. So there is some conversations happening, and that patient did get the care they needed, just so that you know, because we don't want to make out like they didn't, because I think it's really important that we all chip in together and make sure that patients are seen regardless of their status. And the PPCCs is evolving, but if they meet the urgent care criteria, they will be seen. So any issues with PPCCs, just a caveat, I think Jess has popped in the chat, please let us know, because we really want this to work in terms of making sure people get the right care at the right time. So
we've got a couple of questions, or one
Great.
question and one response in the Q&A from Miriam, if you want to have a look at that one, Pip.
yeah, are there any insurance considerations working out of the Medicare, e.g. pro bono? It's a good question.
I would imagine that one's medical defence organisation could probably answer that question. I don't know the answer to that.
We've actually spoken to the medical defence indemnity. One of them, I can't tell you from the top of my head whether it's MIPS or the other one, or MDA, but they've said, yeah, as long as we're treating them within our scope of practice, so whether you're a GP or a specialist or surgeon, then it should be fine.
Yeah. And obviously keeping meticulous notes, as you would do in any case.
Of course.
And,
yeah.
you know, accessing or recording any advice that you sought to enable you to treat the patient is crucial there too.
And we're trying to encourage these patients that when they find a GP to then keep linked with the same one for continuity of care as well. And that's why we thought it was important for them to identify practitioners near them, so that facilitates an ongoing relationship with that doctor.
Yeah. Right. I think Tricia had just popped in again. From a PHN perspective, we really want to support the PPCCs being appropriately accessed and available. So there's an email in the chat. Is there any other final questions or any final words before I do a brief wrap up?
I actually have something I want to just throw in. It's a little bit left of field, but I think it is important to just keep in mind. And it sort of comes from the experience of working over the decades with groups. If we go way back to the Kosovars, the East Timorese and so forth, who have come out of immediate and extreme violence very quickly out of their domains and come to Australia, and also the experience of really working, as all of us have here, with people from different refugee backgrounds, no matter what those contexts, is not necessarily every person is going to want to be referred to or connected to people or organisations that one might naturally identify as having insight into, and at language, religious, ethnic, etc. levels. Some people may well prefer not to be connected to their own community. And as we just, what has evolved sometimes, rarely, but sometimes in the past, is that there are maybe people who will come and their other members of the community hold them in suspicion. So we just need to be open to the fact that there will be all sorts of people from very different circumstances who need to make specific choices about who they connect to and who they don't.
Fantastic. I just want to thank wholeheartedly all of our speakers tonight who have donated their time and have delivered some excellent content, of which we will share across our networks, and we'll have it in our resource with the recording. Really appreciate your time and your expertise. We will, anyone who's attended today or anyone who's registered will receive an email. We really appreciate any of your feedback. I think it's part of the feedback is asking you if you would like further information in any particular area. So I see this as a launch pad to be able to provide some sort of more regular updates or working with our stakeholders around refugee health. Please attend any other sessions, and thank you so much for your time tonight. Thank you to our valued speakers and to our audience.
Thank you to everybody from
Thanks,
Foundation
everyone.
House.
Thanks,
Thank
everyone.
you.
Thank you.
Thank you.
Thanks, everyone.
Thanks.